A 6-month-old patient presents with a severe Staphylococcus aureus skin infection. A blood count reveals a massive leukocytosis, 40,000 white blood cells per microliter. Yet, an examination of the infected tissue reveals absolutely no pus. This presentation violates the basic mechanical expectations of a bacterial infection. The immune system is flooding the circulatory system with neutrophils, but those cells are failing to reach the battlefield. In these patients, the umbilical cord fails to separate for weeks after birth, a delay mirroring the failure of leukocytes to exit the vessel. Historically, clinicians understood inflammation purely through gross anatomy. First-century medicine documented 4 cardinal signs: redness, heat, swelling, and pain. In the 19th century, Rudolf Virchow added the 5th, functio laesa, or loss of function. But these 5 classic signs are merely the macro-level exhaust of a highly deterministic underlying molecular machine. They tell us that inflammation is happening, but they explain nothing about how the machinery operates. To understand the actual mechanics of acute inflammation, we will deconstruct the sequence, not by observing normal physiology, but by examining specific catastrophic node failures. We will map the entire cascade by looking at exact molecular defects, like leukocyte adhesion deficiency, chronic granulomatous disease, acute gout, and sarcoidosis. Identifying a specific molecular failure maps the normal physiological pathway it interrupted. We understand the machine by watching it break. The vascular phase of acute inflammation occurs primarily in the postcapillary venule. This specific segment of the circulatory system serves as the primary staging ground for leukocyte recruitment. This animation illustrates the initial active step, margination and rolling. The leukocytes move to the periphery of the bloodstream and begin a loose, transient adhesion. This tumbling is mediated by P and E selectins on the endothelial wall, binding to silyl-Lewis X glycoproteins on the surface of the leukocyte. Rolling slows the cell down, but it is insufficient for tissue entry. The leukocyte requires a secondary anchor. It abruptly halts when beta-2 integrins on the leukocyte, specifically the CD18 subunit, form a rigid structural lock with ICAM1 receptors on the endothelial surface. This is firm adhesion. Only after this firm lock is established can the leukocyte execute diapedesis. Using a protein called PCAM1 or CD31, the cell physically squeezes through the paracellular junction, dissolving the basement membrane to enter the infected tissue. We can now return to the 6-month-old patient with the paradoxical Staph aureus infection and the delayed umbilical cord separation. The patient suffers from leukocyte adhesion deficiency type 1. This condition is caused by a genetic absence of the CD18 beta-2 integrin subunit. Without CD18, the leukocyte can roll, but it cannot firmly adhere to ICAM1. It is swept away by the blood current. This single missing receptor explains the entire clinical picture. The bloodstream is packed with white blood cells that cannot exit, causing massive leukocytosis. Simultaneously, the infected tissue remains completely starved of the neutrophils required to phagocytize bacteria and form pus. The physical presence of an overwhelming immune force is entirely useless without the specific molecular anchors required to deploy it into the tissue. Now consider a completely opposing clinical failure, chronic granulomatous disease, or CGD. In these patients, neutrophils successfully deploy into the tissue and pus forms at the infection site. Yet the patient suffers from recurrent, deep-seated abscesses that refuse to clear. To understand why, we look inside a healthy neutrophil during a normal phagocytosis event. Once a pathogen is engulfed, it is trapped inside a phagosome, which merges with a lysosome. This flowchart details the oxygen-dependent killing pathway, known as the respiratory burst. The sequence begins with the enzyme NADPH oxidase, which converts molecular oxygen into a highly reactive superoxide radical. Superoxide is rapidly converted into hydrogen peroxide by superoxide dismutase. Finally, the enzyme myeloperoxidase uses that hydrogen peroxide to synthesize hypochlorite, the active ingredient in household bleach, which destroys the trapped pathogen. In chronic granulomatous disease, the patient carries a mutation in NADPH oxidase. The entire weaponization pathway is halted at step 1. Superoxide is never generated, so the downstream synthesis of hydrogen peroxide and bleach completely shuts down. This creates a highly specific vulnerability. Patients with CGD are uniquely susceptible to infections from catalase-positive organisms, such as Staphylococcus aureus and Aspergillus. Normal bacteria produce their own hydrogen peroxide as a metabolic byproduct, which a defective CGD neutrophil can actually hijack to finish synthesizing bleach. But catalase-positive bacteria possess an enzyme that destroys their own hydrogen peroxide. By eliminating the only available source of peroxide, they leave the CGD neutrophil completely disarmed. Clinicians weaponize this exact failure point for diagnosis. We use the nitro-blue tetrazolium test, or DHR flow cytometry. If the cells cannot produce an oxidative burst, the chemical markers won't change color, confirming a broken NADPH oxidase enzyme. Successful inflammation requires an intact supply chain. Neutrophils must reach the battlefield, but they must also possess the functional enzymes required to manufacture chemical munitions upon arrival. Gout serves as a high-fidelity example of sterile inflammation, a process that unfolds in the absence of any infectious pathogen. The trigger is physical. High uric acid levels lead to the precipitation of monosodium urate crystals in the joint space. Under polarized light, these are visually confirmed as negatively birefringent, needle-shaped structures. They act as a potent danger-associated molecular pattern, or DAMP. Local macrophages attempt to engulf these sharp crystals. This causes cellular stress and lysosomal damage, immediately triggering a massive intracellular efflux of potassium ions. This exact drop in intracellular potassium forces the assembly of the NLRP3 inflammasome. Multiple sensor proteins structurally lock together inside the macrophage cytoplasm, culminating in the activation of the enzyme caspase-1. Active caspase-1 cleaves an inactive precursor protein called pro-IL-1 beta into its active form, IL-1 beta. This potent pro-inflammatory cytokine is immediately secreted into the joint fluid. IL-1 beta broadcasts a severe distress signal, triggering a massive, rapid influx of neutrophils into the joint. The resulting swarm causes the intense swelling, heat, and pain characteristic of an acute gout flare. We can abort this exact pathway pharmacologically. The drug colchicine is administered to bind to tubulin, paralyzing the microtubules of the neutrophils. If the cells cannot migrate, the inflammatory swarm stops. For severe cases, we use a biological blockade called anakira. By binding directly to the IL-1 receptor, the drug neutralizes the specific cytokine driving the flare without impacting broader immune functions. Corticosteroids, by contrast, act broadly across the entire system, inducing lipocortin to inhibit phospholipase A2, shutting down multiple downstream pathways simultaneously. Mapping the exact chemical trigger allows modern medicine to replace broad immunosuppressive carpet bombing with surgical, receptor-specific interventions. What happens when the acute neutrophil swarm and the chemical barrage fail to eliminate the pathogen? The system shifts to chronic inflammation. This is a prolonged stalemate characterized by a continuous simultaneous loop of active tissue destruction and fibrotic healing. The primary cellular players transition from short-lived neutrophils to a bidirectional crosstalk between T lymphocytes and macrophages. Th1 helper T cells secrete interferon gamma, which forces macrophages into their classical, highly destructive M1 activation state. When an offending agent cannot be digested, the immune system executes its ultimate architectural containment strategy, the granuloma. A granuloma physically walls off the threat. It is an aggregate of activated epithelioid macrophages. Under chronic stimulation, these macrophages frequently fuse together to form massive, multinucleated Langerhans giant cells, surrounded by a tight collar of lymphocytes. This side-by-side histological comparison illustrates a critical diagnostic differential. On the left is a caseating granuloma, classically seen in tuberculosis. It features a dense lymphocyte rim surrounding a center of cheesy caseous necrosis. On the right is a non-caseating granuloma, which lacks central cell death entirely. Sarcoidosis represents the hallmark of non-caseating granulomatous disease. These are often called naked granulomas because the outer lymphocyte rim is remarkably sparse. Internally, the giant cells frequently contain specific protein calcium inclusions known as shaman bodies, or distinct star-shaped asteroid bodies. Chronic granulomatous inflammation is a highly structured physiological response. It is a specialized quarantine protocol executed when standard elimination fails. The localized actions of neutrophils and granulomas eventually generate systemic shock waves that alter the entire host body. This is the acute phase response. It is driven primarily by three pro-inflammatory cytokines, IL-1, IL-6, and TNF-alpha, which circulate through the blood and act directly upon the liver. This dual line graph plots the kinetics of systemic inflammatory markers. CRP levels surge within 6 hours of the initial stimulus and drop rapidly once the inflammation resolves. In contrast, the erythrocyte sedimentation rate, or ESR, is a lagging indicator. It takes days to elevate and weeks to return to baseline. Furthermore, ESR relies on the physical settling of red blood cells, making it easily skewed by unrelated conditions like anemia or altered fibrinogen levels. Because CRP measures a specific liver protein synthesized directly in response to IL-6, high-sensitivity CRP assays provide a far superior real-time metric of acute systemic inflammation. We have tracked the physical anchors of CD18 required for tissue entry. We mapped the exact step where NADPH oxidase fails in the intracellular armory. We isolated the NLRP3 inflammasome trigger, and we analyzed the structural quarantine of the granuloma. Mastering clinical pathology relies on precision. Every clinical failure, from an absent immune cell anchor to a missing oxidative enzyme, serves as a structural roadmap. By identifying exactly how the machine breaks, we define the exact mechanics of how it was built.